Hi everyone, today we're going to be talking a little bit about assessing a paper, going through some common frameworks about how we can assess a paper and how to think about, in each segment, common downfalls and common strong points to a paper that we can point out. So hopefully by the end of this lecture you'll understand a few different approaches to assessing a paper, be able to effectively use PICO as a method to summarise studies, and understand how to think about high and low quality indicators, and also maybe understand why these things are high and low quality indicators. So generally, the structure I'll use for going through a paper is we'll use PICO to have a think about what is the clinical question, so sort of fundamental introduction to the trial, understanding what its aims are and how it set those out. When thinking about what were the results, I'd refer you back to the p-values lecture to talk a little bit about how to interpret p-values and confidence intervals and think about what those results actually mean. Then we'll go through the quality of the paper, where we'll think about both internal validity, like how much do we trust the results essentially, and then how much do these results actually apply to the patients that we're seeing, which is external validity, which will again use PICO as a framework for assessing. What is next? It's not my invitation to you to guess what's next in this lecture, but the last step of assessing a paper is sort of to think about what are the next steps. So if this is maybe a smaller study or an observational study, is the next step to go on to a randomized controlled trial? If it's a trial, is this conclusive enough that we can use it, or does it indicate the need for more evidence? So thinking about what's the next step in a trial. So this is a format you've probably come across quite often. PICO, it's a acronym essentially for population intervention comparator outcome, our way of thinking how we're going to summarize a trial. I'd add by saying that before going into the PICO format, you should talk about the study type. So a quick, one sentence summary of what the study type is. This is a blinded randomized controlled trial, or this is a prospective cohort trial. And we'll talk a little bit later in this lecture about the different types of, especially observational trial, and how to succinctly describe them. Now, the PICO format is sort of designed for an RCT, but we can very easily adapt it for observational trials. So instead of intervention, that can also be an exposure or prognostic factor. So for example, smoking in an observational trial is not an intervention, but it is the exposure we're looking at. When I say be precise for the population, what I mean is you don't just want, this is a trial looking at adults. We want to know, what does that mean? What does an adult mean? And they'll often specify in that paper. So, this is a trial looking at adults aged between 18 and 65 in the community. So there's often several layers of detail we can get down to. You want a sort of quick summary that gives us an overview of who this population is looking at. Is it looking at medical inpatients, community patients, older adults over 65, etc., etc. And then just sort of hinting at the outcome. It's often not just one outcome. So modern day, especially modern day trials, but also observational studies, will be looking at several different outcomes. And normally these are split into primary and secondary. So that should also probably be included in your summary. And this here is essentially an example of what a PICO-based summary might look at. So we sort of discuss what the format of the trial was. We narrow down our population nicely in a succinct way, saying the age of the adults, that they're in hospital and what condition they're suffering with. We've talked about the intervention, and we've been quite precise there, 20 milligrams of pred. And we've talked about the comparator as well, the placebo. And then we've also highlighted both the primary and secondary outcomes. And this is a very succinct but nice summary of the trial that immediately gives us a sense for what it is, who it's looking at, and what it's testing in a way that sounds quite scientific. And feel free to pause if you want to study this a little bit longer. And practice doing this for papers you read, seeing if you can succinctly describe them in a rapid format like this. So I've talked a bit about validity. And now, so what is validity? Well, generally we split validity into two halves, internal and external. And internal validity is mainly referring to how right are the results you found? Is it because of a true relationship, or is there something in your study, whether that's methodological error or bias, that means that the result you found just is false? That's what internal validity is talking about. External validity is a slightly different question, which is, okay, let's assume that, your results are your results. Even if those results are true, do they apply to the population of patients? So, for example, if you're studying only adults aged 25 who live in one area of Birmingham, and actually as a doctor I'm making decisions in Japan, is your population comparable to mine? Even if you found results that are very valid, does that have any meaning for my population of results? So that's sort of the question that external validity is asking. And really, in trials, is often a balance. So often the higher internal validity, the lower the external validity. And the reason for that is things that tightly control our population, make it very precise, make it very scientific and controlled, will increase the internal validity, but will often make it less comparable to real life. Real life, we don't have very strict trial controlled conditions, and it's a lot more messy. So often things that are a bit more applicable have more problems in terms of internal validity and vice versa. Although there are definitely ways of trying to maximize both of these ideas. So this is a sort of summary slide talking about how we can think about external validity using the PICO format. So thinking about external validity means, can we apply it to general medical populations or my specific population? In P, we're thinking of, is this population representative? So the example I've given here is that most psychiatric trials of new drugs, one, exclude women who might be pregnant, but also exclude those with comorbidities. So a lot of them will exclude people who have alcohol abuse or drug abuse or something like that. And so this makes it easy to control in the trial and make sure I know whether this drug works for this section of the population. But in reality, a large segment of people with psychiatric disorders have comorbidities. And so actually, does the trial that excludes all those people, are those results meaningful when you're applying it to the real world population? And that's potentially something that makes it less applicable. So that's going to affect your external validity. Thinking of your interventions, you're thinking, is this a realistic intervention in the setting that you're working in? So, if the trial, like I said, has daily MRIs, that's, fantastic, that helps, but it's completely useless if you're in a low-income setting where you don't have access to that. Or you might be using, a drug that's not widely accessible. So it can be unhelpful in certain settings. In terms of the comparator, you're thinking of, is the comparator actually fair? So one, are you using the gold standard alternative treatment, which is what you should be doing? So a lot of the time trials might compare to placebo rather than the drug that's actually used, and that's more of a historical problem because you're not really meant to do that anymore. In which case it's very difficult to know, you can't know if it's comparable to the treatment that you're already using. But also there's sometimes problems with not using the same doses, so using doses at the top of the dose range for your intervention and at the bottom of the dose range for the comparator they're trying to prove that they're better than. So although you might have very thoroughly proved that a dose at the top of your dose range is better than the lowest dose range of comparator, that's not necessarily meaningful in terms of the real world when you're going to be using similar dose ranges. And the final one is your outcome actually useful? You can prove that you've reduced triglycerides levels, but is that as meaningful an outcome as all-cause mortality? And what if you're really good at reducing triglyceride levels, but then you look at 5-10 years into the future and actually that has no effect on mortality? So you've got to be a little bit careful about proxy measures, which are essentially lots of these really meaningful measures like all-cause mortality are hard to measure, or deaths, which are rare events. So we tend to use a measure instead of that we think is linked to those longer term outcomes. And we need to make an assessment of whether we think that's a fair link or whether we disagree with that link and therefore are questioning the external validity of the study. This is just pointing back to PICO, which we're going to go through and refer back to this external validity and acknowledging that intervention, exposure and prognostic factor, that's like a wider range in observational studies. So you might be thinking about, is that smoking level realistic? How many people actually smoke at that level, etc., etc. So we sort of ran through in PICO all the different things we're looking for, but we're just going to have a look at, think about where we're going to find those in the actual paper. So in your paper, in the methods, they'll have often a lot of detail on the population, and what you should be looking for is the inclusion criteria. So, who is going into this study, and is that a representative population, but also the exclusion criteria, thinking about, are they excluding people who we are interested in and therefore we're not getting a read on? So the inclusion and exclusion criteria are really good places to have a think about, is our population a generalizable population where we can take those results and apply them to the person we're treating. And we also want to know how are they gathered. And this is especially valid in an observational trial because like how a person is recruited might affect the population you get. So if you've put out an advert and said we're recruiting anyone who's interested in the use of psychedelic drugs to treat depression, and then you put them into a open label trial where you tell them they're going to have psilocybin to treat depression, your recruitment process is slightly potentially biased because you're recruiting people who are already open to the idea of psilocybin and therefore might have more positive results if they know that that's what they're going to get. So you potentially affect the population you gather by how you've recruited it. So you should try and look at that as well. Intervention and exposure, what are we looking for? Well, we want to look for what is it? It will tell you what dose it is, and we want to look at are there several arms and doses, and why have they included those? So an arm is just another treatment. So often you'll have your main treatment, and you might have a high dose and low dose as separate arms, or you might combine them, and you might have one or two things that you're comparing them to. And we just want to have a think about what doses are we using, and are these realistic treatments? And are they comparable? So like I said, are they at the same amount of the dose regimen? And how do they monitor this? So, often in clinical trials, they'll do blood levels or something to monitor that they actually are giving an effective dose. And this can be a rigorous way to ensure that you have valid results. Thinking about the control comparator, again, you just want to check what is the comparator. Is it the gold standard current therapy? Is it a placebo, the sugar pill? Normally nowadays we say it should be the existing gold standard because that just makes it much easier to measure it against actual clinical practice. If in clinical practice that's what they're going to get, you should be comparing to what they're going to actually get rather than a placebo. And that's what you're evaluating, is this the right comparison? And finally, you want to think about outcomes. And we want to think about why they were chosen. So why have they chosen the primary outcome that they have? And is this the right primary outcome? Is this the one that we're really the most interested in? You might criticize a trial that looks at, has a positive result in terms of reducing the triglyceride level of people who you're trying to reduce heart attacks in. And then in the secondary outcome, which is, do they actually reduce heart attacks? There's no difference. You might criticize that for, they've chosen the wrong really primary outcome there. And finally, are they pre-specified? This is referring back to my lecture about multiple testing, but the problem with not pre-specifying outcomes, not saying this is my primary outcome before you start the trial, is if you measure 6 different outcomes, and then you're like, oh, this one's significant, so I'm just going to put that as my primary outcome. That you get a multiple testing problem where you've got 6 chances to randomly find a result, and that increases your proportion of results that are false results. So that's a quick whiz through external validity and how to look at a paper and where to look at to try and answer some of those questions about, is this applicable to a wider population? Internal validity is essentially the degree to which our study is free from bias and error. And probably the best example of a study with really good internal validity is a well-run RCT, which will eliminate pretty much all sources of bias. And a good example of potentially poor internal validity is a poorly run cross-sectional study that is not picking up the right confounding factors and then is drawing these spurious links. And we'll talk a little bit about how to go through studies to assess them for their internal validity. The first thing to say is, we're thinking really here about bias, and you probably have seen this before, the evidence pyramid, where we've got randomized trials at the top, well, just under systematic reviews. We've got, opinion at the bottom. And basically, the higher we go up this pyramid, the stronger the internal validity of the evidence and the lower the bias. And it's just showing this relation of why we potentially value random control trial evidence more than observational evidence. This is an alternative take because, systematic reviews and meta-analyses are at the top of this pyramid, but they're not really new studies. They're sort of like re-synthesizing existing information. So I think it's quite a nice way to look at it as a microscope under which we look and examine randomized controlled trials, cohort studies, case reports, etc. So they're a way of re-examining these to try and get the correct information. And if you see on this pyramid, there's some wavy lines, and this is basically, the idea that it's not a strict pyramid. Not every random controlled trial is better than a cohort study. A really rigorous, well-run cohort study can be better than a poorly run randomized controlled trial. So, generally, as we go up that pyramid, evidence gets better, but you still, that's not a strict rule. If you have a really well-run cohort study, that can be as good evidence as a badly run random controlled trial. The actual quality of the trial or study is also important, as well as just the type of trial or study. And I guess another reason to think about the different types of studies, because different studies have classically different sources of bias. So when we're going to go through some common biases to think about and look out for, but really we need to separate into what studies we're looking at first, because this is going to inform what sources of bias we're really going to interrogate in a paper. So first of all, we'll talk about trials. Blinded randomized controlled trials are the gold standard for bias reduction. In the perfect inverted commas RCT, because a perfect RCT will never exist, there is no bias. You've completely controlled for every source of bias, and it's massive, and you're going to get the correct answer. Well, you're not going to get an incorrect answer because of bias. Random chance still plays a part. So in reality, when we're examining our RCTs, looking for bias essentially is involving looking for deviations from this perfect design, and every place it deviates from that design, we can say, well, this is a potential source of bias because you haven't done this in the perfect way. There are lots of different criteria for thinking about how a study deviates from the idea of a perfect RCT. The Cochrane criteria is a respected criteria used in Cochrane reviews, often considered a gold standard review. And so I've based my talk off these criteria. They are a little bit more complex, so I've tried to simplify them a bit. You'll often see these tables on the right-hand side in Cochrane reviews. And essentially, I think the Cochrane criteria simplify down to, you've got a randomized controlled trial, and is the randomization truly random? Is the first question. Is the blinding maintained? Is the second question. And have we properly collected and reported all the data? Is the third question. So for each of these points, I'm going to talk a little bit about why it's important, and then go on to talk about what good and bad randomization might look at. So randomization is what gives randomized controlled trials their power to explain confounding factors. And a confounding factor, again, we'll talk a little bit about later, but is essentially a different characteristic which is going to affect your outcome if it's distributed differently in the two groups. So, for example, let's say older people are more likely to smoke currently. If we look at does smoking cause hair loss, for example, if we just look at that in a simple way, we'll find, oh, it is associated with hair loss because older people are more likely to smoke, older people are more likely to have hair loss. And so we find a spurious correlation. Now, randomized controlled trials deal with this by splitting people randomly into two groups. And what that means is all of those confounding characteristics are also randomly distributed across those groups. And that means that there should be a fair distribution of all of these confounding characteristics. And so we can essentially ignore them in most of our analyses. And this is the fundamental idea behind why RCTs are so great. Good randomization also prevents not just by chance, you've got these links in the background that are affecting things, but they also affect selection bias. So if I'm a doctor and I'm recruiting people for this new trial for a drug for brain cancer, which to now has been completely deadly, and I know that this patient is really sick and really needs this drug, I might be more likely to try and randomize them to the treatment arm because I want them to receive this new treatment that might save them. And while this is an honourable aim, it would ruin the results of a trial. And it's something that has been seen when splitting people into two arms isn't random. So blind randomization enables this to be overcome because you can't discriminate positively or negatively if you don't know what's going on. So how can we ensure that randomization is truly random? Well, normally in gold standard trials, it will be done by random sequence generation by a computer. So there's no human involved, which might involve error. And also this list should not be accessible by those recruiting. So it's done centrally, and you find out once you've recruited the person which arm they're going into. And you don't even know what that arm is, whether that's the placebo arm or the treatment arm. And this often involves a situation where you sort of like log into an online system, type in a code, and then it will tell you this person is in B or A. Bad forms of this will involve a printed list that the person has access to with, A, B, A, B, so you sort of know which arm they're going into in advance, and that might affect your recruitment. It might involve flipping a coin, something like that. That isn't really that random and requires someone to subjectively read. So computer generation, that's central, and that people out who are actually recruiting patients don't have any control over and don't know about until they've finished recruiting that patient, is a feature of good randomization. Blinding is the second one. Now, why is blinding important? So blinding is important to counter two large areas of bias. The first is performance bias. So we know that people get better when they think that they're getting a treatment that will make them better. That's the placebo effect. And vice versa, that if you tell someone this is a drug that's going to give you side effects, you'll get worse, even if that's a sugar pill that has no innate biological effect on you. So it's really important that people don't know whether or not they're receiving the treatment, or they will inevitably get better results when they know they're receiving a treatment compared to when they know they're not receiving a treatment. Another problem is these non-specific attention effects. So essentially people, like receiving attention from other people and are more likely to be motivated when they have someone, chipping them along. So if you've got a behavioural intervention that, say, is them meeting with a doctor and doing this special psychological therapy 3 times a week for 4 months, and your control is normal, you don't do anything with them, it's very difficult to know, is it that special psychological therapy that's making them motivated to exercise or lose weight, if that's what you're trying to measure, or is it just the fact that they're seeing someone 3 times a week who's going to have a chat to them and say, like, how's it going, and maybe provide advice on what to do. So really a good control for that psychological therapy will be them coming and seeing someone the same amount of times a week, but not doing the special psychological therapy, instead just having a chat with them about something else, or so you need to have a good control for that. And the final one is participant bias. So participants often try to please the experimenters. So in psychology experiments, it's important that they don't necessarily know what's being measured, or they might try and display that because we like to please people in authority. That's just a feature of humans. The other one is detection bias. Experimenters are not neutral in the game here. They often have an idea which they're quite invested in. They want this medication to make a difference, and so they might, if they know that someone's on that medication, be more likely to interpret changes as them getting better. And this is obviously more important with subjective measures like depression measures than it is with something like blood pressure, when you'll click a machine and it will tell you what the result is. But even then you might be like, oh, if their blood pressure isn't getting better, I know they're on the medication. Actually, I think this medication does work. So I'm going to, we'll just take the blood pressure one more time to see if it's a bit lower. And if you're only doing that for one group and not the other, you're going to bias your results. So blinding stops all of those unconscious, often, biases coming in and affecting the results. The other thing to mention here is you often hear the phrase double blind chucked about. It's a bit of an unclear term, and there isn't just 2 individuals who can be blind. There's many groups. So ideally you want a study to tell you exactly who is blind. There's the participants, there's the clinicians who are going to actually be delivering their care on a day-to-day basis, and do they know what's going on? There's whoever's going to be assessing the outcomes at the end. So a lot of times in therapies, blinding everyone is ideal, but sometimes you can't blind everyone. In CBT or not CBT, cognitive behavioural therapy and interventional depression, it's very difficult to blind someone to that because it's an intense 8-week psychological therapy for an hour every week or 2 hours every week. You can't pretend someone's having that when they're not. But what you can do is make sure that it's not the person who's delivering the therapy who's saying, has this person got better? Instead, it's someone who doesn't know whether or not they've had that therapy, who decides how, does the interview to decide how depressed they are. So it's the outcome blinded, even if the delivery of therapy isn't blinded. And finally, data analysis also ideally is blinded, because then you don't have people trying to fiddle with data to find the result that they think should be there. So you really want them to be precise with exactly who is blinded, and anyone who's not blinded is a source of bias. Even if it's impossible to blind, it's still a source of bias. It doesn't mean they could have changed that. And yeah, I guess it's, while saying, this is a potential source of bias, acknowledging that sometimes cases it's very difficult to blind, so it's not unreasonable to not blind people. Drugs have very powerful side effects. It's very difficult to truly blind people to, even if you try. Surgery, it's very difficult to have a blinded control whether you've had surgery, although some studies have done it with sham surgery where they actually put people under anaesthetic and cut into them, but don't do the surgery. But that's obviously quite rare and quite difficult to arrange. So in some cases you can say, look, this is a source of bias, but it's a reasonable source of bias because there's no real other way of running the study. The final thing we're going to think about with a randomly controlled trial is about data, and has it been collected and reported in the correct way. So one potential source of bias is attrition bias. So if we've got loads of people dropping out from the treatment arm because they can't handle the side effects, and then only people who stay in are people who are doing very well, that's going to bias results positively towards the treatment. Similarly, if the trial collects 17 outcomes and only reports 3 of them, because those are the ones that are significant, there's issues with multiple testing, they're not being honest, and that's another source of bias. So that's things you want to look for. Pre-specified outcomes for the last one helps get around that. Finally, I thought I'd briefly touch upon this idea of intention to treat versus a per-protocol analysis. This is something that you'll often see pop up if you ever read about trials. Generally, the vast majority of trials are done intention to treat nowadays. We'll talk you through the fundamental difference between these. Intention to treat, you're analysed according to the arm you're randomised to, regardless of what you end up getting in terms of actual treatment. And in the per protocol, you're only analysed if you stick to the protocol and receive the treatment exactly as you were meant to. And we'll talk a little bit about why this might be a potential source of bias. This is just to highlight what I mean. So let's say you've got 100 participants, 90 complete treatment, 10 drop out or do a protocol violation, they take something they shouldn't have. So per protocol analysis says we're just going to look at these 90. We're going to ignore those 10. They didn't stick to the protocol, they dropped out. So we ignore them, we're just going to look at this 90. In contrast, in intention to treat, we say, okay, we'll acknowledge that 90 completed and 10 didn't, but we'll look at all of them. And you need to find a way of looking at those 10 who dropped out. Sometimes there's various different ways of doing that. So you can look at, the last result they had and carry it forward, or you can try check control for missing data. But fundamentally, we're going to look at all this data. Similarly, this is just sort of showing how this would work on a scale and why this might introduce bias. So let's say we had 100 drug participants who, those who responded really well to the drug stayed in the trial. That makes sense. They're getting on with the drug well, they're likely to stay to the end of the trial. In contrast, those who dropped out or were switched onto another drug, that's because they were doing really badly and they didn't get on well with the drug at all. Maybe we're getting really bad side effects. On the other hand, in the placebo group, we can look at that, it's about those who stayed and those who didn't stay is about the same. About half of them were responding, but actually the ones who dropped out in the placebo group dropped out for other reasons. That's why the dropout rate's lower, just because of life situations or something like that. So now if we do a per protocol analysis, what we're going to get here is we're going to think, oh, great, this drug's better than the placebo drug. Look, it's an 80% compared to a 60% response rate. Fantastic. We've got a drug here that is effective. And this is potentially misleading. If we actually look at the whole sample, the effects are about the same when you average across the two segments. So by just looking at people who stay in, we've biased the results that we're looking at. In contrast, an intention to treat analysis would look at all the results, those who dropped out and those who didn't. And it might do this in a few ways. One would be by assuming those who dropped out it wasn't successful in, for example. And if you do that, you might come to a very different conclusion that actually the drug and placebo are as effective as each other. And so it's just to note that generally we probably want to be doing intention to treat analyses because they're more robust to bias controls, and this is why it can potentially affect the results. So I've talked about the 3 main sources of bias. This is just say, keep on the lookout as you're reading. You might come across other things that seem dodgy. For example, one arm receives an extra treatment that others do not. like the placebo arm gets loads of benzodiazepines to calm them down because they're not getting the psychiatric medication that's working, and this might also introduce a bias effect. Great, so that is a brief, again, pretty rapid fire run through randomly controlled trials and how to think about examining them for internal bias. We're going to move on to talk a bit about observational trials and studies rather, and how to think about examining them for bias. But firstly, we're going to just talk a little bit about the structure of observational studies. So in an observational study, fundamentally what we're looking at is an exposure that happened and trying to see if it's associated with an outcome. So this might be, for example, smoking and cancer. Now there's lots of different types. In cross-sectional, we're looking right now at one slice of time, and we're going to measure the exposure and the outcome, often by asking people, how much have you smoked for how long, and then, how many people have cancer currently, something like that, and say, okay, great, what's the association between here? So that's a cross-sectional study, which is obviously open to a lot of bias. In a case control study, what we're doing is we're again just going now, but we're specifically recruiting people with and without the outcome. So we might say, for example, we were interested in is smoking associated with lung cancer? That's a rare outcome. So in a cross-sectional study, we're not going to find that many people randomly that have lung cancer. That means we're going to have to recruit a whole lot of people, which is going to be very difficult. You need thousands and thousands of people to find enough cases of lung cancer. So instead, what we're going to do is we're going to go to hospital. We're going to look at everyone in that hospital who's had lung cancer. And then we're going to also, at the same time, recruit people who are like those people who had lung cancer in their characteristics, like age, gender, etc., but don't have lung cancer. And we're going to get information about the exposure. So we're going to ask those people, did you smoke? How long have you smoked for? How much have you smoked? So the difference between this and a cross-sectional study is cross-sectional study, we're just taking a random sample of the population, whereas in a case control study, we're going specifically to our outcome and saying, we're going to find people with this outcome. And so a case control study is very powerful for very, very rare outcomes, where if you just do a general sampling, you're not going to find enough people. A prospective cohort study, another type of observational study, is when we recruit people at the beginning and we measure consistently over a number of years exposure and outcomes, and this lets us collect robust data about the association between these. The reason this is good is because we can know what we're interested in. We can make sure at each time point we collect strong data about all of the confounders that we want to, and the data is specifically collected for the purpose of research. So it's often very detailed and nice and thorough, and we're not asking people to remember what they had. We're asking people, great, right now, how much are you smoking? And we're doing that over a series of years, and that's much more reliable. So this is the most powerful, really, form of observational study. A retrospective cohort study is pretty much the same idea, but it's when you didn't go out and specifically make that cohort 17 years ago, but you know that there's information out there. And now you say, okay, I'm going to look back through this information that I know has been collected over a number of years for a different purpose and try use that to answer my research question. So this is also a very strong sort of study, often via medical records. So you go to hospital records and go, great, I've got the hospital records of 100,000 people. I'm going to go back over years and look at, in each time this person came to hospital, how much did they say they were smoking? And then I'm going to look at, diagnoses of lung cancer, and I'm going to try and link them. So this has lots of the same benefits of a prospective cohort study, but you can do it right now. So a prospective cohort study, if you start doing it now, you're not going to get results for 10, 15 years. In a retrospective cohort study, the data's already there, so you can just look at it. So it's much more convenient. However, often you're using information where the data's not been set up for the research purpose, and so there might be errors in it. So, there might be coding errors in a hospital record. They haven't been sampling them purposefully over every year for 15 years. They've come when they've come to present to their GP. So the information isn't perfectly designed to answer your question, and that can introduce some flaws, but it's very easy to do, and so also a very commonly used format. So that's a quick run through all the different types of observational study, and what we're going to touch upon is confounding. So I talked a little bit about confounding variable, but this is just a diagrammatic representation of what we mean. So in an observational study, we're trying to get an exposure and outcomes. That might be A to B. And a confounding variable might be where actually there's this other variable C that is the real link between A to B. And that's meaning that your link between A to B isn't actually because A affects B or B affects A, it's just because they're both related to this other variable C. And obviously that's a bit abstract, so I'm going to use an example. One example might be, if you were to look at ice cream sales and shark attacks, you might find that they're very linked. The higher ice cream sales are, the higher the amount of shark attacks. And this may lead you to say that, oh, you know, selling ice cream causes shark attacks. Now, this is obviously a bit of a joke example, but if we look at why that's the case, that they're linked, it is probably because hot weather means that people want ice cream more, so they buy more ice cream, but it also means that people go swimming more, and you know, the more people swim and surf, the more shark attacks there are. So what we've got is this hidden variable, hot weather, that we're not measuring, which is explaining why these two other variables are linked to each other. And that's a really important thing in observational studies, because it's something we worry about quite a lot, that there's this unexplained variable that's actually causing this link. And so it's something we try a lot to defend against. The way we do this is for adjusting for all the confounders that we can, essentially. So, you know, the minimum that we'd think about adjusting for is sex, age, education level, demographics, you know, for thinking about health outcomes, smoking, drinking. So we should always look at what is this observational study adjusting for in terms of these confounders. And the criticism can be if they're not adjusting for something they should be. So if you're looking at, you know, outcomes in hospital in terms of respiratory disease, and you're not adjusting for does someone have chronic respiratory disease, you should be, because that's obviously a confounder that might very much affect outcomes. So anything that could cause the link between the two things that they're claiming, we should be adjusting for, and we can critique a study if they're not doing that. The thing to remember is, you know, no matter how good an observational study is, fundamentally there are always unknown confounders. So you can always say, you know, this seems to have robustly adjusted for all the things it can, but there may be some unknown confounding, and that might be why we then go on to do a trial to prove what we think. So yeah, confounding very important in observational studies. That's our takeaway, really. So you want to look for the confounders that have been adjusted for, look at what might have been missed, and then think that there's always a risk, even if they're being quite robust. So observational study biases, we're going to think a little bit more about population exposure, controls, and outcome PICO as a way of examining this. So what are the biases in the population? Well, again, it's that those who are volunteering may not represent the wider population of people. So if you're recruiting people to say, you know, we're interested in people who have taken lots of drugs in the past, and then you do a study on them, and then you try make a claim from that group and say it applies to the wider population, that might not be true. You're obviously going to self-select a specific group of people who might have specific lifestyle factors and other things that aren't necessarily representative of your wider population. And so that link you're finding might be specific to that group. Similarly, you want to know that are the populations of the control and exposure relatively homogeneous? You know, are they similar? So if they're not similar, you worry that it might be something else. It might be the type of people who do something rather than the thing itself. So, you know, does cocaine use directly drive MDMA use? It's probably not, but it might just be the type of people who would take one drug, like cocaine, are going to be more open to drug taking in general, and therefore are more likely to take another drug like MDMA. So you want groups to be relatively homogeneous, and if they're not, that's potentially a risk, and you need to be much more careful about controlling for all of those unknown factors and unknown confounders. The other thing to think about is your exposure. So are you getting accurate information on your exposure? So this is especially a problem in things like cross-sectional studies or case control studies when you're asking people to remember the past, because people are bad at remembering the past. And people tend to, if they have a disease, be much better at remembering things that might have caused that disease. We always want to explain why we have a disease. So if you ask people who have, let's say, lung cancer, you know, did you smoke when you were 18? If they did, they're probably more likely to recall that they did, because when they got lung cancer, they thought for a while about like, why has this happened to me? Is it because of that cigarette that, you know, I smoked for 5 years back when I was 18? Whereas people who haven't had disease aren't really thinking about these things that much, and so often have less accurate recall. So that's why, you know, longitudinal studies, so those are those studies that repeatedly measure over years, like a prospective cohort study, are a bit better at this because they suffer less from recall bias. The other thing is measurement bias. So are you measuring things in the same way? So, you know, blood pressures at the hospital versus blood pressures at home. We know that people tend to get less stressed out at home, so their blood pressure is likely to be lower. So if one group is a group of ill people who are always getting their blood pressure taken in hospital, and another group is a group of controls who have just been self-taking their blood pressure at home, there might be a difference, and that might just be because you're measuring it in a different way in different circumstances. Similarly, we've got to think about our controls. Are our controls good controls? So we want our controls to be as similar as possible to the group that we're examining, except in that exposure. So, you know, if we're looking at smoking, we want our groups to basically be as identical as possible, except for the fact that they smoke, because that's going to give us as much as possible isolate smoking as the thing that we're examining. And that means that you often match people. So you often match people for, you know, for age, for gender, for demographic group, because we're trying to like eliminate all of those possible confounders, but also that we need to collect it from the same place. So if we collect, let's say in a case control study, collect people with lung cancer from the hospital and then try to get our controls from people who are healthy in the community, they're going to be different for a whole lot of reasons, not just because they have lung cancer. So instead, what is a better way of doing it is going into the hospital and finding a group of people with other respiratory conditions. So you say, like, you know, in a lot of ways, they're quite similar to a lung cancer group. They have a respiratory condition, they're in the hospital, but they don't have lung cancer, and then comparing those two groups. If they are from different places, you want to look at their characteristics and see, do they have similar characteristics? And if not, you might be worried that it's those other characteristics that are driving your results. Finally, outcomes. You know, how did you, not just what are your outcomes, but how did you get your outcome? And you know, you can also apply this to an RCT, randomly controlled trial. So was it a questionnaire? Was it self-report? Was it medical records? If so, each of those has you know, their own source of problems, and you can mention that when you're sort of thinking about assessing a paper. You know, are they subjective or objective? Is it blood pressure? So something you can be, that's objective, or is it a self-report question about depression where there's, you know, potentially issues in people reporting that? Again, if it's longitudinal, how common are your time points? Are you measuring every year? So you're likely to get a quite accurate, you know, record of how things change, or once every 10 years where, you know, can you say if someone says, I'm smoking at time 0 and I'm not smoking at time 1, you know, when did they stop smoking? It's going to be very difficult for you to pinpoint that. So the more frequently you measure, the more precise your data and the better your data. And again, are they pre-specified? You know, if you're collecting 700 outcomes and looking at all of them, you're going to find a few that are significant, and that's not going to be meaningful. So I've talked in quite some detail about how to think about evaluating sources of bias and presenting papers. But how am I going to summarize it? You'll be doing this as you read through the paper. How am I going to summarize that at the end? So my structure of talking through a paper, if you gave me 3 or 4 minutes to do so, would be to quickly summarize the clinical question using PICO, briefly go through the results of the primary and secondary outcomes using sort of the resources from my p-values lecture to frame the importance and clinical significance of the results. I then go on to, you know, critique the study. So talk about how much do we trust these results, what were the really strong elements of the study or trial, what makes it very robust, and then maybe what makes it less robust, where the sources of bias were, referring back to, you know, both PICO and those special sources of bias that we talked about, you know, randomization, blinding in an RCT, or confounding in an observational trial. Once I'd done that, I'd then finally go through external validity. So not just how much do I trust these results, but even if I do, how much does it apply to my population? And again, using PICO as the basis from doing that. Again, you don't need to do this explicitly, but just picking out the really important parts that may compromise external validity or seem to suggest that it has very good external validity. And finally, just touching on what is next. So, this is an observational trial that shows that steroids are good at treating COVID. The next step is to go on and show this in a randomized clinical trial. So a nod to the fact that you maybe know what the next step in the research process is. So this has been, again, quite a dense lecture, lots of information, so feel free to go back over it. But the final takeaway, I'd say, is that we can use PICO to briefly summarize the general aims and structure of a study. We can then examine these PICO domains in more detail to examine evidence for both internal and external validity. So really dig into, okay, why, not just who is their population summary, but why have they chosen them? Why is this a good thing? Why is this a bad thing? What might be the biases that they introduced here? We can then address, once we've gone through PICO thoroughly, some common other sources of bias. So looking at, RCT, randomization, blinding, have they collected their data properly? And in the observational study, again, thinking about confounding as the really important thing to address, and then also thinking about our data and have they collected that properly. I hope this was useful as an introduction to how to think about bias and how to think about assessing a paper. Again, thanks to Manny for design, and these are the 2 papers which I nabbed those diagrams about pyramids of evidence from. This is just to say there's plenty of other resources to go to if you want to dig a little more deeply into critical appraisal. So there's CASP, which is a critical skills appraisal program. You can Google it. They've got a whole website where they offer online teaching resources. There's also the Cochrane and Grade handbooks that go into a lot of detail on how to evaluate observational studies or randomly controlled trials. That's something I'd go to, especially if you're thinking about this in a research context and you want the top grade evidence. They're pretty dense. So probably not the most casual reading, but if you're looking for strict gold standard ways to investigate a paper in a research context, they're the ones to go to. And again, any feedback is welcome, so please pop here and fill some out and I'll try adjust things. Thank you.